Hi, my name is Dave Dickman. I'm an ophthalmologist with a practice in Rollsville, North Carolina. I opened my practice in January of 2012. I'll be sharing some thoughts with you regarding the Iridex IQ 532 laser, the business of ophthalmology, and how the former can be of benefit to the latter. Let's start with some important but depressing background information. Physicians in general are just not good business people. It's not what we were built to do. It's not what we wanted to do. We all did well enough in school. We're all smart enough. We could have gone to Wall Street and made a lot of money, but we wanted to do something where we could help people at the same time. We're not saints. We didn't become Peace Corps volunteers. Medicine's about halfway in between, I like to think. And in the past, it was enough to just go to medical school and complete your training, and you could practice and treat your patients and do very well. But as the pressures of decreasing reimbursements, increasing litigation, and increasing overhead affects what we take home, we need to adapt. As this slide shows, the average salary of an employed physician, and everything here is in translated to 2012 dollars, it's decreased almost 40% from 1988 to today. Part of that is just that it takes more money to take care of patients today than it did back then. There was an article in Review of Ophthalmology in 2008 that profiled several physicians who opened their own practice. One of them did so back in 1989. He did that with a $30,000 loan. When I opened my practice back in January of 2012, the number was just over $300,000. By the Academy Preferred Practice Patterns, we can't even take care of plaquenil patients anymore without a fundus autofluorescence camera or $60,000 OCT. That's one machine for twice the cost of opening an entire practice 23 years ago. We now have to be very wise in what we purchase. That same doctor back in 1989 helped to support himself and pay back his loans by assisting on cataract surgery. He was reimbursed $1,400 for each case. Now we're reimbursed about $700 for being the primary surgeon. You're not even allowed to have an assistant. So when I opened my practice, one of the only pieces of new equipment that I purchased was this, the IQ 532. I think that besides the slit lamp, this has been probably the most useful piece of equipment for my business and my patients. It's of potential benefit to diabetics, glaucoma patients, central serous patients, high myopes, people with lattice. Here's a list of procedures that I can think of to do with the IQ 532. I'm sure there's a couple more that I just haven't thought of yet. Personally, over the last 11 months, I've done 6 different things on this list with the IQ 532. Let's take MicroPulse Trabeculoplasty as an example of how we can put the IQ 532 to good use for the benefit of our patients, our practice, and really the healthcare system as a whole. Glaucoma medications are expensive. Yearly cost ranges from $160 to $743, and averages $475 a year for prostaglandins, which is what I use as my first-line medical treatment for glaucoma patients. That's well more expensive than even if you were to do an MLT on every single glaucoma patient every single year. And that does not take into account the patient's time and effort in obtaining the prescription, your time and effort writing the prescription, dealing with your buggy e-prescribing system, speaking with pharmacists on the phone. And it also leaves compliance in the hands of your patients who may or may not be equipped to deal with that. Here's an example illustrating this over a 25 patient sample size. If we were to treat 25 patients and even if only 20 respond, we've cost the healthcare system just over $10,000 and we've generated just under $8,000 for our practice. In year 2, assuming no loss of efficacy of the laser, the cost for caring for those 25 patients is just the $23.75, which is the cost of prostaglandins for a year. If we do MicroPulse in no patients, then we've cost the healthcare system almost $12,000 every year. So even over a 2-year period, by doing MicroPulse in just 25 patients, you're saving the healthcare system about $10,000 and you're generating almost $8,000 for your practice and also saving your patients a bit of money. Who do you offer MLT to? Really anyone who doesn't have a contraindication, the main ones being uveitic or traumatic glaucoma, or someone whose glaucoma is so advanced that a transient pressure spike will snuff out their nerve. I certainly don't attempt to talk patients into the procedure. Same as any procedure, I present to them the benefits and risks of medication. And I actually use myself and my mother as an example. My mom has glaucoma. She was followed for many years as a glaucoma suspect. Eventually they said, hey, you missed a couple of spots on your visual field. Last year, you missed a couple more this year. Your pressure's creeping up. Here, it's a bottle of Zalatan. Take it at bedtime. She's been doing that every night for probably a decade. But my mom doesn't take many systemic medications. She has a good insurance plan. Her copay is relatively low. I, however, I'm a terrible patient. I can't even remember to take multivitamins every day. I'm not a good candidate for medical treatment of glaucoma. For me, laser just makes more sense. I also ask patients about their copays. You know, if your patients have a copay of $3 or $5, it's a lot different than if they have a $30 or $50 copay. They're a lot more likely to be compliant with medications if their copay is lower. But even if their copay is low, if they're on a ton of systemic medications, it can still be a financial burden, and you'll be doing them a favor by offering them MicroPulse laser trabeculoplasty. Glaucoma patients who are already on more than one medication without good control are also good candidates for MicroPulse treatment. That's the case with the patient that I describe here. This patient was a 78-year-old Caucasian woman referred to me from a retina colleague for management of glaucoma OU and cataract OD. She has dry AMD on the right, wet on the left. She's status post Eylea injections on the left. She's had cataract surgery on the left. She's had macular pucker surgery on the left. Her vision is 20/40 minus on the right, 2400 eccentrically on the left. Her angles are open. Cornea is mildly thick. But her pressures are 22 on the right, 21 on the left on 3 different medications. She's using dorzolamide 3 times a day on the left side, Istalol in the morning on both sides, and Zalatan at nighttime on both sides. So here's a patient who's on plenty of systemic medications. She has multiple eye problems, and she's on a complicated medication regimen for her glaucoma. I felt that her pressures of 22 on the right and 21 on the left were just too high for someone with these problems, and I suspected problems with compliance. Initially, I asked her to just change her medication regimen. I said, let's take Cosopt twice a day rather than the dorzolamide and timolol separately. Thereby, we can decrease how often you're taking drops throughout the day, decrease the number of bottles that you have to worry about. I asked her to come back in a week for glaucoma testing and to recheck her pressures. That is a little more quickly than I usually have a patient come back after a medication change. But this is a lady who's got glaucoma eating away at her peripheral vision. She's got macular degeneration affecting her central vision, and I was a little bit worried about her. At the 1-week follow-up, we did glaucoma testing. Her visual field shows superior nerve fiber bundle type defects. HRT3 showed low rim volume and area and thinning of the rim on the right eye. It also showed borderline cup-shaped measure on the right and high on the left. At that visit, though, her pressures were great. They were 12 on both sides. Unfortunately, she got confused. She was still using all of her old medications, and she was using every one 3 times a day. So clearly just altering her medication regimen was not going to do the trick for this patient. Also, I worried about her pressures fluctuating throughout the day. So we decided to proceed with the laser in the hopes of stabilizing her pressures consistently at the 14 to 16 millimeters of mercury range, and then perhaps to reduce the number of drops that she's taking. MicroPulse laser therapy with the Iridex IQ 532 was performed on the left eye initially. Prior to treatment that day, we gave her a drop of brimonidine to prevent a pressure spike. Using the laser's continuous wave setting, I placed several test spots to titrate the laser power using a 50 micron spot, 100 millisecond continuous wave exposure, starting at 500 milliwatts and increasing until a slight blanch was noted in the pigmented trabecular meshwork. The IQ was then changed to the MicroPulse mode with a 15% duty cycle. Spot size was increased to 300 microns and duration to 300 milliseconds. If we assume that Schlem's canal is 36 millimeters and we divide by our 300 micron spot size, we should be placing about 120 spots, and that's what we did here. Here's a brief video of that laser application. No medications were administered after treatment. Patient was instructed to continue her glaucoma medications, but I did ask her to stop the Acular that she had been using in that left eye that her retina doctor had given her. Asked her after treatment, I didn't give her any medications after treatment, but I asked her to stop the Acular that her retina doc had her on just for 4 days. 2 weeks after the first eye treatment, she was using her drops appropriately. Pressure was 13 on both sides, although in the untreated eye it subsequently rose to 18. Visual acuity was unchanged. I saw her a bunch of times between March and June because besides the laser, she also had cataract surgery in the right eye. But since the MicroPulse laser, her pressures have been stable at the 11 to 12 millimeters of mercury range. I saw her back in September and asked her at that time to stop the dorzolamide and just use Istalol in the morning and Zalatan in the evening, and actually saw her a couple of days before Academy. Unfortunately, she was confused again and was still using all of her old medications. So clearly this is somebody who doing laser on is a good idea, because medications, she's just not going to be able to manage them long-term appropriately. So as I mentioned in the introduction, I like to give patients a choice of the laser or medical therapy. In the past, when I've been at practices that only had an ALT, I was much less likely to offer them that because of the potential side effects, lack of repeatability, and just technical difficulty in doing an ALT. SLT and MicroPulse both appear to offer the benefit in terms of complications, repeatability, and technical ease. And in my opinion, they're superior to argon because of the lack of thermal damage to the tissues. MicroPulse with the 532 to me makes a little more sense than SLT because there may be less damage to non-targeted tissues due to the MicroPulse setting. But also, business speaking, the cost of an IQ 532 is less than a used SLT, and an SLT you can use for one thing, and that's it. This we can use for at least a dozen that I can think of. It is great for retinal issues as well. I've used it in continuous mode to treat retinal tears with barrier laser. I've used it in MicroPulse for focal and grid treatments, and recently I used it to perform MicroPulse, panretinal MicroPulse phototherapy. I don't say photocoagulation because there is no coagulation. Benefits to this over standard PRP are no coagulation, so you can apply it. You're applying it contiguously. You're treating more retina with this laser than standard PRP because they're not going to lose vision every time you place a spot. Also, it's safer. I remember as a resident having the retina doc standing over my shoulder. You could pretty much feel his blood pressure rising because he was sure you were about to zap his patient's fovea. With MicroPulse, you're meant to go through the macula. You're meant to go through the fovea. It's okay. You don't have those worries. So recently I saw a 62-year-old Caucasian woman who had a branch vein occlusion in the right eye in the past and had subsequent proliferative retinopathy for which she had received standard PRP 3 times in the past. First time she had the PRP done without any block. She had so much discomfort from that her next 2 PRPs She had a block done and had to leave the office with a patch over her eye. So she came in to me with a complaint of blurry vision and floaters in that right eye for the last 3 or 4 weeks. Her vision surprisingly was slightly better on that right eye than the left, about 20/30, 20/40 on the left side. Pressures are about 17 on both sides. She had an inferior nasal defect on confrontational fields consistent with her branch vein occlusion. On dilated exam, she had mild to moderate dispersed vitreous hemorrhage. She had some small areas superiorly of more dense hemorrhage. She had an epiretinal membrane in the macula of the right eye, and she had scattered PRP scars, a bit less than I expected for somebody who had 3 PRPs in the past. She was a very, very nervous patient, so we had decided to sit on it for 2 weeks, have her come back, redilate, and pending a good view of the retina, to apply MicroPulse panretinal therapy. This is the video applying the laser. You can see the 2 test spots there, but here where I'm doing the actual MicroPulse treatment, nothing. We're not harming the retina. So I placed those test burns with 100 millisecond, 200 milliwatts, 200 micron spot size on the continuous wave, and then changed to MicroPulse and did 200 milliseconds, 400 milliwatts, and a 200 micron spot size, and performed fill-in therapy confluently. So here's what you take home. The IQ 532 is versatile, at least a dozen uses that I can think of. It's cost effective. It generates more income for your practice. It simultaneously is decreasing your patient's out-of-pocket expenses and decreasing total healthcare dollars spent for treating a patient. It makes procedures like trabeculoplasty and focal laser and panretinal laser easier to perform and safer for your patients. Thank you.
Thank you very much.